Each episode, we're going to dive into evidence-based strategies, cutting-edge research, and real-world insights to help you elevate your practice and empower your clients. Okay, so welcome to the Rehab Blueprint Podcast. Okay, welcome to the podcast. I'm excited today. We're going to be talking about some interesting topics, but before we get into it, welcome to your own podcast, Giles and Luke. How are you feeling?
Yeah, I'm good. Thank you very much. Living the dream. Just want to say we've had our new book published, and if it wasn't for these guys, Brogan and Luke, helping us with that project, it wouldn't have come to market. So that's going to be out in a couple of weeks. So thank you for helping on that project.
Thank you for having us involved. I'm excited to see it come out. And a lot of the stuff we've been talking about over the podcast has been in that book, hasn't it, really?
So great.
How are you doing, Luke? I saw you've been doing a lot of running.
Yeah, man. Clocked off a 17K yesterday. Can barely walk.
17K.
I've been skipping a few runs the last few weeks just because when I was coming towards the end of my weightlifting program, looking to max out, I wanted to save the legs a bit. Yeah, doing me no favors.
You were feeling some neuroperipheral or general fatigue overarching from workout to workout. Likely not CNS fatigue. Anyway, I love it, how every time we get into making a post, it seems like if there's debates all through our industry, it's just, and you walk into some debates without even knowing it, and you're like, whoa, people have an emotional opinion about this one. So today we're going to be talking about sustained mechanical traction for the purpose of long-term remodeling of the spine. I'm specific in how I'm saying that because we are not talking about necessarily short-term. For example, pain modulation through changing the position of the spine, as we know that works. McKenzie is very popular. Putting somebody into a position of extension seems to be okay and can modulate pain in the short term. And so it's important for us to reiterate before we go into this that we're not attacking that. It makes obviously no sense to attack that. Short term, there are some pretty cool outcomes when you can mess around with someone's anatomy, physiology, and their structural biomechanics. And when someone comes in with lower back pain, that is quite common. Again, the McKenzie method is pretty popular at this point. One of the things they're very well known for is extension, right? Prone extension to kind of restore what would be a derangement or some type of directional preference, apply a directional preference. And so I just wanted to start with that. Another thing I want to say is sometimes when we're talking about these things, I'll have friends or colleagues reach out and be like, who is even saying these things? They don't even believe the things that we're trying to discuss or we're trying to debate because it seems so wild. But this stuff is happening. And I'm especially talking about the X-ray episode and what we're talking about today. And it's all over social media. In fact, this episode today is inspired by a series of posts and a series of accounts where these long-term mechanical traction interventions are happening via chiropractic care. And these people are posting all over social media claiming absolute miracle stories when in reality the research, the evidence is just not there. Just to frame the episode, I think it's important to say that there are people out there doing this in 2025. For some listening, it may be like, is this really happening? Are people really strapping people up to these traction devices and leaving them for an hour and then claiming they're fixing their whole life? Yes, it's happening. I've sent a few posts recently to the guys and it's pretty shocking that it's still happening. Were you guys surprised to see it occurring? Probably not, I suppose.
I get triggered, man. I get triggered when I see this absolute freaking nonsense on social media because it's very reductionist when I see it. I will talk more about it a bit later. It's strapping people by their feet to the ceiling and doing yanking their necks or strapping them into machines and pulling and pushing. What I'm seeing now is it's not just this, it's sensationalization. It's just this need of therapists to create sensationalist posts for traction, for clicks and likes. It's these therapists desperately chasing these vanity metrics. Oh man, this post got 100,000 views and I've got some woman in a bikini strapped up like 50 Shades of Grey with a freaking banana between her teeth. And I'm correcting her C-curve. Let's see how many likes we can get. It's crazy. But the problem is it's getting worse and worse and worse. It's this weird one-upmanship. Yeah, it's a crazy world.
I agree with Giles. In the world of social media now, everything is for clicks. You think about the way you can actually make money on social media. You can sell pictures of feet, pictures of your hair, pictures of, whatever, pictures of bald heads, who knows? But This is, I think this is just where it stems from realistically.
Luke, just sorry to cut you off, but I was talking to Brogan on TikTok. There's a UK-based osteopath who's being paid commission to advertise these postural correctional devices, which have no validity, no real evidential backing, and I don't even know where the ethics stand. Like as an allied health professional, as a regulated osteopath, I go through a 5-year degree. I have to follow, the NICE guidelines. I've got to follow the ASA, the Advertising Standards Authority. And if I stand up on social media and I'm selling utter fucking nonsense, how are these regulators? Why is my governing body not going, oi, you freaking numpty, wind it in, or you're going to get struck off? Because it is modern day snake oil. It just absolutely, it baffles me how people can spend so much time and effort to get qualified and then screw their ethics and just fucking flush it down the toilet for a few quid on TikTok. It is just, see, I'm getting triggered, man. I've got to calm down.
I would say the same with our governing bodies, but then you look at the chiropractic governing body and then you're like, oh, they're just as bad. Like they're not governing anything.
And do you know what the thing is? So the General Osteopathic Council, I've got a massive issue in the UK with our governing body and the associations. I don't think they're fit for purpose whatsoever. And I think it needs a huge overhaul. But they turned around the other day and they went, we're not prepared to lobby government. It's not in our role. We're not here to support the osteopaths. We're here purely to protect the public. And I'm like, okay, well, if you're going to do that, then why are you not clamping down on social media with people making these utter nonsense claims in regulated countries for money? Why are you not clamping down on it? It just, if you're there to protect the patient, stop these therapists talking crap for cash, because it's not professional, it's not ethical, and it's not science-based. And it's actually causing the profession massive amounts of harm. I think it makes us look like absolute quacks. I think there really needs, like you and I can discuss it. We can sit here and stick a podcast out and go, But until the fucking governing bodies actually pull their finger out and actually do some work, I think there's a lot of questions to be asked.
Absolutely. This, what you're saying is very true. We see so much of this pop up. I think our algorithm especially tends to send this towards us just because it gets a reaction out of us. But we're getting to the point now where we're starting to unfollow or block because we just don't want to see it. And this is what led us to this. We've been doing a post. We've been openly kind of advocating against x-ray use for spinal misalignments and apart from red flags. And so our algorithm starts to show us these videos. And what we started to stumble on is things that me and Luke were stumbling on and learning about when we were in chiro school. And that's these chiropractors strapping people up, x-raying people, saying that their lordosis is flattened or they have a reverse curve based on arbitrary norms and averages, which make no sense anyway, then strapping them to a machine and claiming it's, sagittal realignment or remodeling of their lordosis. And then months later, x-raying them again and Harry Potter, poof, wonder, sprinkles on top, the person is completely fixed and their spine is remodeled. There are so many issues along the way with this type of intervention and treatment, of which one of them is the methodology or the current methodologies of many of the research studies around this intervention. I'm going to go through and talk about 6 different reasons why I feel not only the intervention of traction can be problematic, but even the studies surrounding it can be, especially when you have chiropractors still doing these interventions, going into the comment section and defending themselves, dumping all these research articles that lack any method-based rigor, they're not appropriately powered, and people are posting them like they are a gotcha. And so that's really a problem, because not only are you seeing patients undergoing this treatment, but then you're seeing other allied healthcare professionals being influenced through this information, which is potentially dangerous. Again, just to reframe what we're talking about, there's a lot of crazy things we see on social media, but we are zoning in on the traction, sustained mechanical traction in this episode. There are various things we can talk about, and the fact that we see so much of this on social media is alarming. I think before we get into the nitty gritty, one of the things I find difficult about it is that people feel like x-rays are very medical, they're very important. And when they come in and see you and they have pain, and then you take an x-ray and you assign their pain to the structural changes on the x-ray, which we know is not evidence-based. And then, not only then do you tell them that and you give them a diagnosis, but you strap them up to a machine and tell them that you're fixing an arbitrary lordotic number, and then that's going to fix their pain. And then we have these people kind of telling these miracle stories. It is like deeply unethical. And these chiropractors may be posting a few of the stories that work, And maybe they're working for other reasons, the other types of movement and exercise interventions, time, regression to the mean. There's all these other things that the studies can cover. But the reality of the situation is that how many people are actually being likely hurt from this or taking advantage from this? How many patients is this hurting? Because that's what I'm concerned about. The people that are doing well, they're the exception to the rule. So you see some people that do well with spinal traction, they're the exception to the rule. What about all the other people that aren't doing well under that care, that needed proper intervention, and instead they've been given this quackery? That's what personally I am worried about. So when we look at actual traction itself, again, we're looking at, hey, are there going to be long-term changes to someone's pain, injury, function, and health through mechanical traction? So for those that aren't fully aware of what we're talking about, it's when a chiropractor will strap you up into a certain position for a prolonged time. They are strapping you into that position for a long period of time in hopes of remodeling your spine. Okay. When we go through and we look at the validity of this, number one, traction actually fails under any legitimate systematic review or meta-analysis. So when we actually take time to look into the research, it is clear. Number two, structural abnormalities don't predict pain or disability. It's a real issue to extrapolate results from an X-ray and then treat it with traction. How are we assigning pain and pathology to something that's on a scan? Which leads me to number three, poor diagnostic validity of imaging for MSK pain. So we know there's a high prevalence of abnormality in asymptomatic individuals. There's so much happening on a scan that's not going to show up functionally or even as pain. So how are we using X-rays as the key diagnostic assessment tool? Radiographic images are unreliable as an outcome measure. And so what we mean by that is it's very, very difficult to take an X-ray at the start and then take one at the end based on how many factors can change the way the person is standing. Number five, it contradicts clinical practice guidelines for spine pain. No major MSK guideline recommends traction or routine imaging for non-specific spine pain, so that's a problem. And then number six, there is no universally accepted normal spinal curvature. Normal spinal curves are like a statistical average and not clinical absolutes. There's a high variability in spine shape among asymptomatic individuals, and static X-rays don't reflect dynamic or functional adaptations or changes anyway. That's 6 reasons shooting from the hip. I'm going to spend a little bit of time going through and making some sense of that. Any thoughts before I start going through the numbers, guys?
That's right. We'll dive into it.
Okay, so number one, traction fails under systematic review and meta-analysis. When we look at the highest quality evidence, Cochrane reviews, meta-analysis, systematic reviews, we repeatedly find that spinal traction has minimal to no effect on pain, function, or disability in most MSK populations, including people with lower back pain and neck pain. If we're talking about symptom management, so extension, McKenzie protocols, changing somebody's movement based on the pain they are exhibiting on that day, or pain modulation through movement, that is fine. But long-term remodeling, no. There's a Cochrane review of 32 randomized controlled trials and systematic reviews. Within this, their conclusion was these findings indicate that traction, either alone or in combination with other treatments, had little to no impact on pain intensity, functional status, global improvement, and return to work among people with lower back pain. This is a gold standard systematic review. Now, this is where things get even more alarming. Adverse effects were reported in 7 out of the 32 studies. And these adverse effects were increasing pain, aggravation of neurological signs, and subsequent surgery. So there's actually a percentage of these studies that showed that, hey, it actually made things worse. When you look at the first study in the meta-analysis or in the systematic review, Brogan's ETL notes, previous trials to assess the efficacy of lumbar traction for back pain have been methodologically flawed. And this is one of the reasons why this overall review was put together, was to show that when we look at the highest evidence, it's quite clear what's happening. And the reason why we do that is because there are small studies out there that are showing contradictory outcomes. Further support my statement, there is a systematic review of spinal decompression via motorized traction for chronic discogenic lower back pain, and that has 121 patients, and that's 10 studies. Now, 7 of those studies that are high quality randomized control trials with a control group show no improvement. But then the 3 unrandomized non-control studies of that review all showed 77 to 86% improvement. So within that review, you've got this clear dichotomy and differentiation between when we've got a rigorous, solid, controlled methodology, we're not seeing an improvement. And then we've got a methodology where we're relying on people to come in who kind of know what's happening to them. There's no control group. There's no blinding. Then all of a sudden, they are feeling the benefits. That's a problem. There's other research as well. Brogan's ETL, 150 patients, no significant difference between groups. Clark ETL 2006 was a review. Again, no statistical difference between. Fritz Barrett's 2007 RCT, no added benefit from traction. Heart ETL, 30 patients with nerve pain, no significant improvement. Cross ETL review article, no long-term improvement. Vanti ETL RCT, short-term only. Thackeray ETL, no additional benefit from traction. We can go and go and go and go with the quality evidence showing that sustained lumbar traction is either not doing anything or it's short-term. So yeah, based on the information that we have at hand, do you have any thoughts, Luke?
Yeah, I mean, you sort of covered the research, and it just sort of sums up the poor efficacy around the research when it comes to traction, and sort of these professionals that we talked about, or so-called professionals, continuing to use it purely for the clicks. We're not saying that can't be effective short term, but likely when it comes to long-term changes, we need to pair it with things like exercise. The more concerning part that you touched on, adverse effects that are coming from these studies, so increased pain and aggravation of neurological symptoms, just highlight that potential risk of using traction if that's sort of your main modality or basing your entire clinic off that. And it just emphasizes the need for more evidence-based approach to pain management and sort of long-term correction.
Yeah. And one of the main issues we look at when we come across these types of studies is if they don't have a control group, if they're not double blinding, it's very difficult to look at the outcomes, especially with chiropractic, when a lot of the people in this industry are getting people to participate in these studies that are like students or other chiropractors and are very aware if it's not double blinded, whether they're getting a real traction or a sham. And then if there's no control group at all, then it's even worse, right? But even if there is a control group, it's still very difficult. And me and Luke have been involved in research like that, where you go in knowing full well what the intervention is. You know if someone's going to check and adjust you, if you're going to be a sham, and that in itself, that lack of rigorous blinding is highly concerning. So number 2, structural abnormalities do not predict pain or disability. Okay, so multiple high-quality imaging studies show poor correlation between spinal curvature or degenerative changes and pain. This is significantly concerning because these chiropractors are assessing the person, they're x-raying them, and then they're saying that their spine is either too hypolordotic or too hyperlordotic based on arbitrary numbers. And then they're assigning their pain to the structure on the x-ray, and then they're proceeding to treat that with traction. That's why the x-rays are so closely linked to this, because they're not MRIing these people. They're not doing a fluoroscopy. They're not getting a functional read. It is an X-ray. It's a superimposed 2D moment in time. It's an issue, right? So there's a substantial amount of research that shows there's no association between pain and reverse cervical curves or lordotic curves. And that's another problem. If there's no connection between those two, why are they using it as an assessment tool? Okay, so Bellatios ETL study compared radiographic imaging of injured and non-injured participants. However, when they tried to draw a correlation between spinal injury and poor postural curvatures, they could not. There was no significant difference between both groups. In addition, Christensen and Hartington systematic critical review found there to be no association between postural curvature and overall health. Murray ETL reported no link between a reverse lumbar lordosis and pain either. And in 2014, Kumagi ETL studied over 700 volunteers. When they tried to link sagittal cervical alignment and neck symptoms, once again, they came up short because they could not do it, concluding there was no association present. Moreover, Matsumoto ETL prospectively studied over 1,000 cervical x-rays, so 495 asymptomatic, 488 had acute whiplash. His overwhelming conclusive results showed no significant difference in the cervical lordosis between these two groups, concluding that reverse postural curves are likely a normal variant and not pathological. Okay, so the overwhelming amount of non-biased literature supports that lordosis or reverse postural curves are not associated with pathology or pain. So how we can be using this as a primary driver for treatment is unsubstantiated, not evidence-based, and very concerning. Giles, do you have any thoughts on that?
It's funny, you guys have discussed some really interesting points over the last sort of few minutes, and there's so many things that could be unpacked and discussed. I was like, there is so many different thought processes. Look, from a manual therapy perspective, I have no issues with people using gentle traction to try to create symptomatic modification. I've got no problems with that. Right, it's fine if it's part of a manual therapy process. Some patients might like it, some patients don't. All right, whatever works for the person. When it comes to this use of x-rays to then diagnose these tiny changes that then you introduce the traction to, I actually look at that as almost clinical reductionism, right? So it's funny, like we talk about like this, it was the buzzword, it's a bit like fascia, holistic. It's this holistic buzzword, right? You look at the person, mind, body, spirit is what we used to say in osteopathy, or the three-legged stool. Do you remember that stuff? You know, but as we've already discussed, clinical thought process, case history, discussion of the patient, why this person, why this issue, why now? What is the underlying factor? Is it neurology? Is it musculoskeletal? Is it movement? Is it stress? It's a big, broad process. And to be a true holistic therapist, you have to go through this big case history discussion process, looking at multifaceted aspects to really identify what is the issue for that person. You know, we talk about that Punjabi theory, those three phases. We talk about looking at the person, right? But to then throw everything away and then just use one X-ray and go, that small movement issue is your problem, that is your pain, is probably some of the most reductionist, narrow-minded, ignorant thought process I could really ever think of. And it's ironic that these people say that, oh, well, I'm an alternative healthcare practitioner. I look at the whole person, yet you're just going to base everything you do on a single X-ray and this one sort of intervention. It's not holistic. It's not patient-centered. It's reductionist. And it's almost mono-interventionist. It's like, well, this one technique will cure them all. And I'm like, well, actually, no, that's fucking nonsense. Yeah. And it's a real shame that there's this sort of dogmatic thought process that these therapists, and it's a difficult one because are they being unethical or are they being uneducated? And it's a really difficult one because I look at the posts and I think, oh my God, that's outrageous. But then I think, well, who trained them? Who taught them that? Where did they learn that? How has that not been challenged? And so it's a real difficult one when you look at it.
Just on that point, I agree. It could be ignorance, but the issue I have is when you start seeing them arguing in the comment section, not listening to the research, right. And you click into their profile and they've got hundreds of thousands of dollars worth of 50 Shades of Grey pulley systems that they're using to yank people's spines out of existence. Like, they're not going to listen to.
You've got all the gear and no idea. That's what we used to say. What the problem is when you have someone who has heavily and financially invested in this modality. So if I'm saying to you, right, Luke, if you've spent $10,000 on a piece of equipment, I'm telling you, everyone that comes into your treatment room is going to get that piece of equipment. You are so invested in it through a financial aspect, through the whole sales pitch of it. I mean, and we don't have to look at manual therapy. We can look outside of manual therapy into all other aspects of the world and religion and so, everything. It happens in all industries. When you are so invested in this one thing,
it's the same with chiropractic too. You spend 25 to 30,000 on a drop table. Most clinics have those drop tables, like hydraulic, whatever, and then another 40, 50 grand on those insight scans. So already you're accumulating 100,000 worth of expenses before you've even started up practice. So it's like, it makes sense. Well, it doesn't make sense, but
bro, what about the money of the X-ray machine?
Yeah, true. Yeah, that's another.
So people listening to this podcast, like say the old chiropractor is listening and he's got like $100,000 X-ray machine. And he's like, oh, all the research they're going through. Are they going to listen? Like, why would they listen when it's going to?
Well, they're not going to, and that's why they're
going to challenge bias of their back pocket, the wallet in their back pocket, isn't it? So
you're basically insulting them personally. They've invested their whole professionalism in this one thing, and you're going, it's rubbish.
Yeah, and that's the thing, and it's important to reiterate that that's certainly not our intention. Like, we definitely aren't trying to personally attack people, and that's why we're touching on. The only reason we're touching on this is because there's enough misinformation that we need to, and I've been seeing it perpetuated over and over on social media. But the X-ray thing is interesting, right, to bring up, because we just talked about how the structural abnormalities don't predict pain or disability in terms of reverse curves, which is like the bread and butter for people that are trying to do traction. But then if we go to point 3, we also have poor diagnostic validity of imaging for MSK pain. And what I mean by that is, oh my days, people are walking around asymptomatically with all types of changes, okay? So due to the high incidence of abnormalities found in asymptomatic patients, the diagnostic validity of X-rays can be question when used in isolation of history or proper clinical assessment. But look, when we're looking at it, Curie ETL reported that out of 75 detected bone injuries on scans, only 30 were symptomatic. Okay. Hauger ETL found that when scanning 115 uninjured asymptomatic adults, 97% presented with some type of abnormal knee finding. Furthermore, things get even more increasingly concerning when we look at back pain. Okay. So 2015 literature review consisting over 3,000 asymptomatic individuals, 37 and 96% had disc degeneration, up to 84% had disc bulge, up to 83% had facet degeneration, up to 50% had a spondy, all asymptomatic, pain-free individuals. Okay. So many of these guidelines, and we'll talk about it real soon, but many of these guidelines from the United States and Europe are discouraging the routine use of x-rays for lower back pain without red flags. Research shows that using x-rays prematurely in cases where there are no red flags can actually have a negative health outcome on the person as well. Increased radiation, more doctor follow-ups, more pain, more overall dissatisfaction. There's research supporting that. But then when we look at other parts of the body, when it comes to patellar tendinopathy, we can have improvements or lack of improvements, and they don't show up on scans, or they do show up on scans. 37% of pain-free 20-year-olds are increasing up to 96% by the age of 80 are having disc degeneration. Shoulder impingement. Studies have found that reduced subacromial space isn't correlated with pain or function at all. Rotator cuff tears. Research indicating that 23% of pain-free individuals between age 50 and 59 have rotator cuff tears, and that goes up to 51% in those that are 80, but they have no pain. Hip abnormalities. Right? Participants revealed abnormalities in 73% of hips, labrum tears, and 69% of the joints, suggesting that these structural changes don't equate with pain. They're asymptomatic. Meniscus tears, over 60% had them, no pain. I mean, I can go on and on. I won't. The point is that we cannot be drawing correlations between structural changes on a 2D superimposed blue and black image and then assigning that to someone's pain, following that up with traction. Following on from that, the radiographic imaging is also unreliable as an outcome measure. And what we mean by that is variability in patient positioning, equipment, and the interpretation of x-rays is unsuitable for tracking these types of interventions and these changes in a proper study, right? So if you're putting this into the methodology, it's going to lower the quality of the study. Accuracy can be questioned, but from the first x-ray to the second x-ray to the final x-ray, depending, based on patient positioning, patient physical and morphological changes, doctor interreliability, stress, pain, patient's night's sleep, physical activity, hydration, or emotional state. What we're getting at is that when you ask the patient to line up to be x-rayed, they are going to stand differently. From one x-ray to another, it's not high quality of a diagnostic tool to be used to be able to support a narrative that something like traction is working. There needs to be a better methodology within these studies. Luke, we went through this firsthand, didn't we?
Yeah, 100%. And there was, I can't remember if you touched on that study when it looked at the Cobb's angle shifting by, 5 degrees when they took a bunch of orthopedic surgeons, scanning patients at 8 a.m. versus 8 p.m. And it changed depending on the time of the day. So it just questions the reliability of using these x-rays.
And that's scoliosis. That's a medical condition.
To track like postural, subtle postural changes or alignment across weeks or months. If that's changing within a day, less than 24 hours, why are we looking at someone's scan from 2 years ago?
They were looking at scans, making decisions on scans that are outdated, and then you go get a new scan and you're like, oh, they've improved, and then you're assigning all the every other single improvement that that person has had, whether it be through your care or anybody else's care. They may have gone through a divorce, they may have lost their job, and the opposite may have happened. They may have had the best, 2 years of their life, and they've come back and you've re-imaged them, and now you're taking all the glory from your traction when they may have improved due to many other therapeutic interventions or reasons in their life.
Even briefly, like when you touched on all those statistics regarding findings on imaging with asymptomatic patients, well, it would make sense that the more common a finding is in asymptomatic people, the less useful it becomes in determining what's actually causing pain. So, imaging is going to lose diagnostic specificity when everyone has something on their scan.
Yeah, and even when we use our hands-on skills and we're trying to relate this information to, like we've already talked about, Punjabi or Fryett's Law, and they have these methods and these philosophies of how the spine moves. We know that it's all heterogeneous anyway. It's all different. Every Tom, Dick, and Harry, they had a different idea of how the spine moves. So how can you derive clinical meaning of how to treat that from something that is not consistent in the literature or consistent from philosophy to philosophy? You can't do it. You just can't. There's so many cracks in this ideology. It makes me sick. Number 5, It contradicts clinical practice guidelines for spine pain. This is very simple. So no major MSK or pain management guideline. So NICE, ACP, APTA recommends traction for spine pain. Over the past few decades, medical boards, health associations worldwide have made a substantial move and effort to communicate better when you should be imaging full stop, right? With most education being around the reduction of x-rays in medical cases that do not present in red flags. Yet, x-raying somebody for a traction treatment becomes the standard norm. Just put them in the x-ray, a few months later, put them in the x-ray for post results, get your marker out, do a draw, put it on social media and claim that the person's better. The guidelines don't suggest it, so why are we doing it? The American Board of Internal Medicine's worldwide initiative, Choose Wisely, we've talked about this before, they openly advocate for better dialogue around unnecessary medical tests. And one of the things they touch on is x-rays, right? Are they needed unless there's red flags present? No, not for postural little misalignments or subluxation, things we can't define medically. No. And the Australian guidelines have advised against diagnostic imaging for routine assessments of back pain. Major concerns around the world of unethical use of imaging. It's not just us talking about this on this social media, talking about this on the podcast. There's so many people in the medical system that are worried about this. The American Academy of Family First Physicians recommends withholding imaging for lower back pain within the first 6 weeks of symptom onset unless clinical red flags are present, obviously. And the American Association of Neurological Surgeons and Congress of Neurological Surgeons recommend withholding all imaging of the spine in patients with non-specific and acute lower back pain without red flags. So if you're wanting to traction them, these people first have to get them in the x-ray booth. That's not suggested by the guidelines. That's not suggested by the MSK pain management guidelines or professional bodies, nor is traction part of the guidelines or is suggested anyway. I mean, Giles, you just talked about this with a beautiful rant before. You were leaning towards some of the other things you see on social media, but the same thing goes with this, doesn't it?
I always think to myself, right, what I find quite funny is these educators or these universities who are teaching these young students to do this repetitive x-ray to then utilize the types of spinal changes through traction, are they not sort of sat there on their sort of coffee mornings going, why are we the only ones in the world doing this? Why has everyone else stopped? Why has everyone else decided that they shouldn't be doing this? Are we the mavericks here and we know best? We know better than all other medical professions, all other hospitals in the world, all other educational providers. It's just us. We've got the magic sauce. We've got the secret sauce to cure all. Do these people not sort of sit there and look at what else is happening globally and go, hold on a minute, why are we still doing this if everyone else has stopped? It's sort of, why are these... I mean, you don't go to any real hospitals that I've seen and go to their MSK ward and they're freaking spinal changing, curving, strapping, whacking these patients around. It's just not done. It really isn't. It's nothing that we were ever trained in or even taught, because a lot of it, as I said earlier, this is common sense stuff. This is sort of anatomy and physiology 101. You talk about things like, I don't know, what was it? Wolf's Law, fiber is laid down in lines of stress and the remodeling process. You look at that type of thing and the time and effort and days it takes to do any form of structural changes. And I'm like, and they think they're getting these amazing results within these tiny periods of time. It just blows my mind why these educators are still purporting this type of thought process. But it's not just those guys. There's all the postural stuff and all the other things that we can go on about, trying to almost make the perfect person in this structural biomechanics, which is never really, you're never going to make the perfect person. There is no normal. There's no perfect.
And touching on that is number 6. There is no universally accepted normal for spinal curvature. So
have you ever seen a normal patient? So I'm going to be honest, right?
Yeah.
I've never, ever seen a normal patient. What is normal? I've never seen it.
There's a set of averages.
It's exactly, but everyone is so uniquely different. Yeah, fine, okay. We should all have a head. We should all have limbs. We should have certain things in certain places, but it's not a guarantee. What I find is quite funny is you get these therapists going, I'm definitely on this, I'm definitely on that. And I'm like, well, actually, how do you know you're not? Because If we look just on the anatomy side, there's soft tissue structures we may or may not have. Suboccipitalis minor, we may have rotorius, stenolis, pyramidalis, palmaris longus, tertius, psoas minor. All of these muscles may or may not be present in the patient. Anatomical variations of bony structures, the sacrum, the transverse processes. There is no such thing as normal, and trying to chase that normalized perfection. It's quite funny. I work with a guy called Dr. Kunasingham, amazing orthopedic foot and ankle surgeon. We wrote a book together, and he turned around. I said to him, we were talking about this biomechanical perfection, and he turns around to me and he says, the patients sometimes come in and they turn around and they go, I want this beautiful foot, because he's a foot surgeon. He goes, I want this beautiful foot. And he turns around and he goes, I'm not here to make porcelain patients. I need to make that foot structurally strong, mobile. I need to fix the issue that it is there. If I make a beautifully perfect foot, it is going to be a porcelain thin veneer that's just not going to be fit for purpose. And we are not here to make porcelain patients. We're not here to make the biomechanical perfection that does not exist. We're here to try to make that person move as well as they can, as pain-free as they can, for them. And that's it. If that means just putting their shoes on without pain, well, that could be a win for them. If just picking up their kids, that could be a win. I am not going to try to turn someone into a perfect porcelain patient, because it is never going to happen. And it's impossible to try to achieve.
And when you start going down that slippery slope, it becomes exactly that, a slippery slope, because you're starting to assign pain to some arbitrary number of what should be normal for the person that's sitting or standing in front of you. You're measuring their lordotic curve, and then you're coming to this conclusion that they're hypolordotic or hyperlordotic, and then you're applying traction to bring them back to what would be normal, as we just talked about. What is normal? What there is a series of averages that we understand, but that doesn't necessarily mean we have to move towards those averages. I find a real problem with this, and there's no evidence that this normal reliably predicts pain or dysfunction. That's really the crux of this argument, isn't it? Targeting curve correction assumes there's a problem that doesn't exist. There is no normal, only sets of averages. What is hypo versus hyperlordotic? That's the issue. Terms like hyperlordosis or hyperlordosis imply there is an ideal spinal shape to strive for. There's a porcelain perfection out there.
Yeah, the only way you are going to get a perfect spine is with Harrington rods, right? It's to base that's the perfect. Yeah, you've got to surgically rod that bad boy, and that's how you'll get a perfect spine. If that's what you want,
what's perfect anyway? Like what numbers are you going by? What is the ideal base of arbitrary reference range that you're going to go by on that day?
Exactly. And ironically, do you know what you look at different cultures through different historical time zones, and what was normal back in the day was an obese person in some cultures, or in other cultures having massive elongation of the cervical spine through ringlets.
Imagine taking an average from one of those populations and then working towards that average as being your norm that you're trying to achieve. You got everyone on track. You got every single person on traction for the neck because all of our cervical spines are too short.
Or shall we crack our feet and bind them like they did in Japan or in China with foot binding? Let's just smash the feet, wrap it up, and then we can, over months and months, we can have these tiny little feet, because that's the average. It's just ridiculous.
It's going to be different whether I get, 8 hours of sleep a night versus 4, whether I drink a liter of water a day or whether I drink 5. And outside of the anatomy, when it comes to normal that you guys touched on, like just generally looking at someone's lifestyle, is normal. Are we looking at an office worker, or are we looking at a cyclist? Are we looking at a cricket player? Because when you're imaging, it's just it's a static snapshot in time, and it doesn't account for how the spine adjusts to various loads, stresses, and movement patterns over time. So
it's probably one of the smallest parts of the process. It's a bit like It's a bit like focusing. If someone wants to completely change their physique, change their body, have a massive body, transformation, and all you're focused on is making sure that they drink an electrolyte first thing in the morning, right? You don't bother about diet, training, nutrition, sleep, lifestyle, stress, exercise, whatever. Let's not worry about that. Let's worry about the one tiny little insignificant point that may, help some, a fraction. You're just throwing everything away.
It's not just the clinical relevance, but it's the academic relevance when people are using these, what are meant to be averages, as norms to then push a method forward and to prove a bias through like a study. That's also a problem. So there's like an academic issue with this as well, right?
But people will jump on the bandwagon and go, "Oh, it's in a research journal. It's in a book. It must be true." Harry Potter is in a freaking book. I listened to an argument on there was a research done about what's wrong with osteopathy, and there's lots wrong. But they had this website, they had a podcast, and there were an osteopath was arguing about the benefits of this very esoteric type of cranial work. And he's got this book, he's waving a book, going, "I've got the book, it's in a book." And it's like, dude, there's a lot of really bad fucking books out there. I should know. I've written some. No, but there's a lot of really bad books, really bad research. Just because it's in a book doesn't mean it's true. Yeah. There's a book on probably vibrational, spiritual energy healing through the eyeball for treating bunions. Doesn't mean it's true.
Yeah, there's fiction and non-fiction, so probably falls into one of those categories.
Exactly. It just blows my mind. It's in a book. It's in the research. Have you read the research? It was done on fucking anesthetized cats.
A lot of stuff is actually, there are a lot of cadaver studies out there that people will quote as human trials. They don't understand the difference, or they've just read the title, not even the abstract. And then you go and look at it and you're like, that study is not even saying what you think it is. Maybe the spinal norm is from cat, like the lordosis and a cat.
Seriously, my days. It's just like, read the abstract, don't read the journal. Christ, if you're going to be lazy, just stick it into ChatGPT and get them to read it for you. If you can't be bothered to read, get them to consolidate it for you.
But you got to be careful because ChatGPT gets a lot wrong.
Well, yeah, absolutely. It does very much.
Like, it's funny because you only notice it gets things wrong when you're asking it.
Know about it.
Yeah, and that's what I'm so concerned about, because I'm like, if you're trusting it on things you don't know about, I'm like, hey, every time ChatGPT gets something wrong, it's only in something I'm an expert in. That's a problem. That's a problem, isn't it? Yeah. But anyway, sorry, back to what I was saying. These terms like hyper or hypolordosis imply there's an ideal spinal shape to strive for, like we just talked about, which is kind of ridiculous. But this ideal is based on arbitrary reference ranges, often derived from this is what I wanted to touch on. These ranges are often derived from outdated cadaver studies, small radiographic samples, or people with unknown functional baselines. Now, the last one's the key one, because we don't know. These averages are drawn from a set of people. We don't know anything about their pain, structure, or their function. And that's what makes this so concerning. You cannot assign somebody's pain to an arbitrary made-up lordosis stat. You just cannot do it. There's a wide natural variation that exists in asymptomatic populations when it comes to this. Reference norms are often based on standing static postures, so they're going to be inaccurate across the board for functional outcomes. Postural abnormalities don't correlate with these outcomes. Correcting towards arbitrary norms ignores individual adaptation, and biological systems are not linear and self-organizing. So trying to standardize spinal curves in the same way we measure blood pressure is a category error. Structure doesn't behave in that kind of linear, predictable way. It is just again, like I said before, it's the heterogeneous nature of spinal alignment. What are we trying to achieve when we're bringing somebody who's hyperlordotic back? Now, if they're in pain, that pain could be caused by many things, of which you should do a proper comprehensive assessment and history and figure it out. Because just taking that and putting it down in your notes as another reason why you should put them on traction is extremely problematic. Now, again, there are other ways to increase your lordotic curve potentially. And for example, the lock method had this in there somewhere in there. Not many people talk about it, but if he was noticing based on the patient in front of him who was doing a specific to task movement and required more lordosis or less lordosis, now this is based on the functional outcomes. Powerlifters tend to have less, but that's because they're under compression. They need it. right? Versus a gymnast is going to have more mobility. They're going to have more of a lordotic curve. They need it for motion. But based on the person that he would see, he would do functional testing, muscle testing. He would test the thoracic and the lumborum components of the spinal extensors, iliocostis lumborum, etc. And sometimes he would prescribe muscular work of those muscles to try and enhance what would be the lordosis. He's not strapping people down to a static, harsh, strong one position. Like, it's through motion, muscular contraction, it's through proprioceptive training, it's through progressive, planned, periodized rehab that we're going to get those types of results out, and potentially he might get a change in that person's lordotic curve. But it's not the postural static lordotic curve that he's worried about. It's how the lordosis is functioning under load, and it's how the lordosis is functioning and interacting with velocity and power when they're moving as an athlete. Does that make sense? There's a little bit of a sidebar, because I don't want to throw out the baby with the bathwater, because sometimes it is appropriate to look at somebody's curvature, but it's case by case. There's no standard set of norms.
You've basically highlighted clinical thought process. You basically, the therapist is utilizing clinical reasoning, assessments, movement. They're using tasks. They're getting a wider picture of that person's issues, and that's going to direct them to utilize an intervention, whether it is to increase, decrease, improve movement, decrease movement, whatever it is that they're going to do through clinical thought process. And you don't get that with a static image. You only get that through verbal dialogue, discussion, and testing and movement.
Yeah. Any final thoughts, Luke?
No, man, that was good. A lot of information in that pod, but I was glad to get through it all.
Yes, we try to keep it short. I know we got a lot in there. Feel free to reach out, message us on our social media, send Giles an email because he loves those, and ask questions if you want to know more, because we're happy to talk about it.
Yeah, you can even contact me on social media and I'll block you.
Yeah. I'm going to include the show notes. So click through and read the show notes so you can go through every single study. We have listed every single reference to support what we're saying, and to really land the plane and be very clear on our conclusion. When we're talking about it today, we've discussed not only the intervention of traction and how it can be problematic for long-term, expecting long-term structural remodeling, but we've also talked about how the methodology of these studies that are telling you it works are so flawed because they're using it through an X-ray diagnostic criteria, and that is also a problem. Not only that, but clinically they're also using the X-rays as well, and that's something that we have to talk about because it's closely linked to traction, because that's their justification for the traction. Okay, so that's why we've touched on it, just to be super clear. I'll include all of the information. Like I said, go read it for yourself, critically think, don't just take our word for it. But we want more people understanding these concepts, because I want to see less of it on social media. When it comes to these types of things, use some critical thinking. Check us out on YouTube, check us out everywhere you listen to your podcast. If you want to engage, go to our social media, OMT Training and the Rehab Professionals. There's plenty of good courses up on the OMT Training platform. Plenty of them are free. Get into it and learn. We'll be back next week. Anything else from you two lads?
No, good one, guys. Really good to see you, and thanks very much indeed.
Yeah, man. All good over here.
Have a fantastic week, and we'll see you next week. Each episode, we're going to dive into evidence-based strategies, cutting-edge research, and real-world insights to help you elevate your practice and empower your clients. Okay, so welcome to the Rehab Blueprint Podcast.